I'm Jonathan Galley. I'm Dr. Blackburn's kind of co-fellow, if you will. It's really wonderful to be here this year. I missed last year's session. My little one was born like 2 days prior, so I'm really fortunate to be here this year. I'm from the University of Utah, planning on staying there and doing autoimmune neurology, and I think you guys will hear a little bit more about our fellow projects going forward, I think later tomorrow. But what we're talking about now is some really promising news in the NMO world. Dr. Levy gave a great lecture earlier about NMO and kind of the two-pronged approach in treatment where we're, first putting out the fire and then second, making sure another fire doesn't happen. This is a really great topic. This year, it's been a really exciting year where, in 2018, we really had no great guidelines as far as medications for NMO. We kind of all had a practice pattern. It was kind of, well, we might put you on mycophenolate. We'll probably just throw you on rituximab and go from there. But in 2019, 3 great trials came out. And the first FDA approval came out for an NMO medication, eculizumab. And so today, I'm going to have our panel members chat a little bit about their respective medications and trials, and then also get the input of Dr. Levy and Dr. Greenberg on how these new medications change our treatment and try, I guess, to convince me not to just throw my patients right on rituximab. So without further ado, let me introduce in order Dr. Katz, Dr. Bambry, Dr. Levy, and Dr. Greenberg.
Take questions for.
We could just play Jeopardy. I have some slides.
That's fine.
Should I?
Yeah.
And then no. Yeah.
Okay.
Should I stay here or stay?
Right there. Oh, you can stay right there.
I don't want to take you.
No, you're good.
Can push him aside. Maybe I can even sit even better. So, my name is Ellicott Katz. I'm Vice President of Clinical Development at Viela Bio, which is a relatively new company that's spin-off of MedImmune AstraZeneca about a year and a half ago. When I joined, and this is a real story, when I joined MedImmune about 7 years ago, I was recruited because of my overall experience in immunology, and I was told that I'm going to work on inflammatory bowel disease. And the first day I arrived, I went to my boss' office, and he told me, Ellie, I thought about it. I don't want you to work on inflammatory bowel disease. I want you to work on our NMO study that we're just thinking about. And I looked at him and I said, Joren, what is NMO? So just to show you, as you know, that even in the medical community, this disease, until very recently, or still, require a lot of education. It's a rare disease. Not everybody knows about it, and definitely a lot of, as Michael mentioned before, a lot was done in the last decade to really understand it and to improve the overall understanding and the treatment. So we launched about 6 years ago, 7 years ago, we decided to launch a study in NMOSD to try to see if our medication can work. Next slide, please. I'm moving. I have it here. Okay. So this is my disclosures. So we decided to take our drug, which is called inebilizumab, and what it does, it basically attach to if you want to call it like a keyhole. Here's the key, and this is the keyhole. Keyhole on the lymphocytes, the B lymphocyte. And by attaching the key to the keyhole, you get a process by which these B cells are just being disappearing. They're just being killed by the medication. So what we call it, it's a B cell depletion. We deplete the B cell from the circulation. And as you see here, it's depleting cells from early on when the B cells start to develop up to the plasma blasts and plasma cells that are the cells that actually produce the antibodies. So we decide based on different experiences and understanding of the NMO, because the aquaporin forest you heard play a major role, we think maybe if we deplete the B cell, we can get, you know, an effect. This is the drug and shows you here how it attached to the lymphocyte, which is a big blue thing at the bottom, and how it creates other cells to come in and actually kill the B cells. So you, of course, I don't need to tell you how difficult it would be or should be and was to run a study in NMOSD. Because of the rare disease, there are not many patients. In order to have a study who is meaningful in the results, you need to recruit quite a bit of patients. So the only way to do it was that we actually went to 25 countries, and we was working with about 100 hospitals around the world. In the US, in South America, in Europe, in the Far East, in Australia, in New Zealand, in South Africa. So in order to get the patients that can be participating in the study, it was a lot of effort. We decided, because there was no medication approved at that time, to compare our study, our drug, which is called Irmedi 551, to placebo. In other words, to no treatment. This create, and Ben remember, and Michael remember the big discussion and the emotional charge discussion that was in the community. Should we do, or should we allow to do placebo study? In other words, to take patients with NMO and put him on nothing for half a year. I don't want to go to this discussion right now. If you have questions about it, we can discuss it later. But we thought that this is actually the right thing to do in order to get an answer which is unequivocal answer. And we did it, and as you can see, many patients around the world agree with that, and physicians, and we went ahead and do that. So what we checked is, after the patient put on the drug for 6 months, how many of them basically develop an NMO attack, an NMO relapse, which, as Michael said, this is the most important thing, clinical event in NMOSD. So this is what we did. Now, at the time we started the study, there was no unified, agreed upon, clear criteria how you diagnose an attack. So we put a lot of effort with the community, with experts. We have a steering committee of about 12 people that we work together to try to put clear definition of what attack is in order for the study to be meaningful and able really to provide good data. So that's kind of how we did it. I don't want to go into much detail, but we developed criteria that all the investigators that involved in the study used the same criteria to make the diagnosis, and then it was reviewed by expert group of 3 experts in the field that approved the decision of the investigator that actually was an attack in the study. And we use some criteria and some MRI images, depends on the situation. Again, this is the show you the process by which we went. Any patient who was suspicious of NMO attack came within 72 hours to the hospital, got an assessment by the physician that should have been done in 5 days, and then the adjudication process to make sure that actually it meets all the criteria. These are the 3, and maybe you know some of them, the 3 experts that were in our adjudication committee, Dr. Weinschenker, Dr. Green, and Dr. Wingerchuk, that no doubt are experts in the area. This is the result that Michael also showed you. So after running a study for about 5 years overall, we got to the point that we have the results. We got the result late last year. Actually, it was around Christmas of 2018. And as you see here, you're comparing in the blue the treatment versus the placebo in the gray. And as Michael mentioned before, we have a very significant benefit here for the treatment with 77% reduction of the risk of attack in the aquaporin 4 seropositive population. This was the 6 months of the study, as I saw you before, that the study was only for 6 months because of the placebo. Here it's the result after we continue to follow the patient for 1 year. Very similar, and we have now about 180 patients now actually in the open label study. In other words, all of them getting now the medication. After they complete the 6 months, they're moving into what we call open label, where everybody gets the drug. And we keep following them. There are many of them now 2 or 3 years after the study. Our secondary endpoint that look at disability by measuring what we call the EDSS shows significant improvement on the therapy. MRI lesion were significantly lower in the treatment arm, and hospitalization was lower on the treatment arm. We check also visual acuity, which didn't show significant difference, and we try to understand exactly why. We believe some of it has to do with the complexity of the methodology, but the fact of the matter is that we didn't show here a significant difference. Safety was, of course, in any study like this, when you have a new medication, you need to look at safety, because if the drug is not safe, it may be very effective. If it's not safe, it's not good. So as you see here, the profile now for at least 1 year, looking at the data, show us that we didn't see any major issues related to the drug. The most common was a urinary tract infection, and then all kind of other infection of the nose and throat, back pain. Some people respond mildly to the infusion, some joint pain and headaches. One thing to mention, we had in the open label, after the randomized control period, we have 2 patients who died. One died clearly from NMO attack. The other one, we are not sure what she died from. It was in Mexico. We end up doing all what we can to make a diagnosis, but we were not able to make a final determination. So that's about it. So after about 6-7 years of real efforts, and it takes a lot of people to work on, a lot of time, a lot of money, and a lot of dedication from the team, for the patients that allow us to do the study, and the physician, we are now in a situation that we apply to the FDA, and we're waiting for the FDA decision as far as approval of this drug for therapy. Thank you.
Let's see if this reaches. All right. Good afternoon, everyone. I just wanted to thank the TMA for inviting us all here to speak with you guys and answer any questions you may have. So my name is Ankur Bambri. I work with Alexion Pharmaceuticals. I'm a family medicine physician by training, and about 1.5 years ago, I started working with Alexion and their medical affairs team. Alexion as a company has been around for quite a while now. We have 4 therapies for 6 different disease states. Most of them are all rare diseases. The therapy used in NMOSD is called eculizumab, or also known as Soliris. And this medication has actually been around for a long time in a few other diseases. So the same medication is approved in a disease state called PNH, atypical HUS, and then recently generalized myasthenia gravis. So we've learned a lot about this medication, the benefits it has in these other disease states, and also some of the side effect profiles that it can have. But the success of eculizumab in treating NMOSD patients has really developed from the NMOSD community. So way back many years, as back as 2007, the community discovered that there is a role of this complement system involved in creating the NMOSD lesions. So this developed what we call a proof of concept study, where the experts in the NMOSD community, the physicians, the patients, and the researchers did this study with a small group of about 14 patients to see how this medication would work. And what they saw was that eculizumab would increase the duration, or increase the time it would take to have a relapse in a patient. So Alexion took this information and made this a little bit more global on a scale with a much larger study, 143 patients, included many countries. And the goal was to compare this against placebo and see how this medication would really work in NMOSD. Patients were allowed to be on many concomitant standard of care medications. There was a few exceptions to that. But what we saw with this was that this trial, which we called the PREVENT trial, showed that eculizumab actually decreased the risk of relapse. And if you put that into terms of numbers, it was a 94% reduction in risk of relapse in eculizumab compared to placebo. So we were very excited about this news. With the PREVENT trial, a little more information. With any medication you're on, you always have to look at the side effect profile, because every medication will cause side effects. So some of the most common ones we saw were things like nasopharyngitis, which is this inflammation in your nasal passages or the back of your throat. You could have what we call upper respiratory tract infections, sometimes might be referred to as the common cold, dizziness, diarrhea, back pain. These were some of the adverse effects you can notice from this medication. One of the most important things to know about eculizumab is it does come with what we call a black box warning. And a black box warning is introduced to a medication if there's any potential serious adverse effect that could occur. And with eculizumab, the requirement is that, the warning is that it could potentially cause a meningococcal infection. So what do we do for this? So there's actually a prerequisite for eculizumab, which is a meningococcal vaccine, and it's required that you get this vaccine at least 2 weeks prior to starting the first dose of medication. So that's kind of eculizumab and Solaris in the PREVENT trial overall. Fortunately, with that PREVENT trial, it went just recently in June, the FDA reviewed it, and it got approved, as many of you are aware, for the treatment of adult patients that are AQP4 positive or aquaporin-4 positive, sometimes referred to as seropositive disease. And we are approved in neuromyelitis optica spectrum disorder. So again, this commitment from the NMOSD community has really developed from start to finish the approval of this medication, and we're very excited to have options now in NMOSD.
I don't have any prepared remarks, but we were both sites for these trials. We're very familiar with the drugs. We have lots of patients with NMO. We've been thinking through what drugs we would use for which patients. So I think if we would open the panel to questions that our host can moderate, you can ask me or Ben or Ankur or Ellie anything you want, basically, right?
Yeah, that sounds great. Before we open the floor, the one question that I have is, as these are coming out, from your standpoint, how do you go about making a decision on which drug to choose, especially once we've got real solid data on, these 3 drugs? How would you, in your clinic, go about making that decision?
So the way I do it, and for those of you who are my patients, I think you've experienced this, I kind of present it like a menu. We go through the disease, we make the diagnosis, and then I say, okay, let's talk about treatment. On the preventive side, here are your options. We talk about which drugs they are, how effective they are, what their safety profile looks like, and then all the logistics like cost and is it IV or sub-Q or how often you'd have to take it. And then I really try to put the decision in your hands, and you talk about it, and I say, don't rush. If you want to call me, you can call me, or if you have an answer right now, we can get it started right now. I'd say about 75% of the time the patients have their own priorities, and they'll say, well, I want the safest, or I want what I perceive is to be the most effective, or I can't afford $20 for every copay, or whatever the priority is. Everyone has their own set of priorities. And I don't think there's a wrong answer. I think whatever you decide is best for you is what we go with, and then if we're wrong, then we can adjust. Only a rare minority will say, okay, I don't know. I don't want to take part in this decision. What would you do if I were your daughter or sister or whatever? So really, I enjoy the discussion, and I like hearing what your priorities are, and I think it's always best when it's a group discussion rather than me making a decision for you. Is it different in your clinic?
We have a dartboard, and you get a dart, and whatever it lands on. So It's very similar, and before I give my answer, just from the full scope of things, and Michael referenced this in his talk, so it's a little repetitive, but just to be clear, as eculizumab has achieved FDA approval, and eculizumab is in front of the FDA, there is another agent that Michael referenced in front of the FDA, satralizumab, and this is a product, again, Michael referenced, and we were both sites for, which is a once a month injection of an agent that interferes with signaling pathways of the immune system, something called IL-6, which achieved its primary endpoint of preventing relapses in a very similar way to the other drugs. The only reason I mention it is there was fascinating bits of data that have now been presented publicly relative to the satralizumab trials, and they actually did 2 worldwide trials. And to cut to the chase, they saw a preferential benefit in people who were positive for the aquaporin 4 antibody. And so the robustness of the impact was very clear if you had the antibody, whereas if you were diagnosed with neuromyelitis optica spectrum disorder and were antibody negative, the value of the drug was less clear. And this is a pattern I think we're seeing in different places. And so when it comes to personalization of medication selection, we do take into account somebody's antibody status, because I think what we've learned through the clinical trials and through genetics studies that we've done and immunology studies that we've done is if you truly are negative for the aquaporin 4 antibody, it may be a very different biology that gets you to the phenotype of having spinal cord and optic nerve involvement. There are lots of ways to damage the spinal cord and optic nerve. Aquaporin 4 antibody is one, but there are many others. And we saw this with the AntiMOG antibodies. A lot of patients who look identical to an individual with an aquaporin 4 antibody have a different course of events over time. And so we are going to be separating out our patients to whether or not you're antibody positive or antibody negative, and we're looking to see how the FDA handles this in terms of labeling for the next 2 drugs that they're considering. But similar to Michael, we have a very personalized discussion with our patients, and I think the biggest question we're facing right now in our clinic is, hey, Dr. Greenberg, I'm an NMO patient of yours, I've been seeing you for years, and I'm on drug blank, fill in the blank, either mycophenolate or rituximab is probably the 2 most common. And most of my patients who are doing well, who haven't had a relapse in 5, 6, 7, 8 years, 10 years since they've been on the drug, will ask me, should I switch now that there's something FDA approved? My personal general advice has been, if it's not broke, don't fix it. If you're doing well on the agent you're on, stay on it. It's going to be an interesting world to see how third-party payers handle these different agents, as some drugs are FDA approved and some aren't. I don't expect for them to restrict access, but we're all waiting to see how they handle that. So for people who are established, we stick with what you're on if it's working. If you're a brand new patient and you come to us, and let's say all 3 get approval. Right now it's just eculizumab. We don't know what the FDA will do with the other 2 products, although we fully assume that they will be, I can say this, I fully assume they're going to be approved. What we don't know is when somebody comes to my clinic, will I be just talking about those 3 drugs, or should I still talk about other 2 that don't have data from placebo-controlled trials? In general, we like to go where there's data, and that's the reason we did these trials. And so it's going to be an interesting conversation for patients who have yet to be diagnosed.
If I may add something here, I think the question that you ask is the question that, as everybody aware, is being asked everywhere now. Okay, assuming, as Ben said, only 1 drug is approved now, the inebilizumab, our drug is not approved yet, and the other one still not approved. But assuming that the 3 drugs will be available in the next year or so, what you do with them, how you make a decision. And I think the answer to that is probably 1 word: time. We need to get experience. Everybody needs to be experienced with the 3 drugs and the situation that Ben was talking about, that somebody is stable on a drug, what you do with him, what happened. Now, in some way, although everybody wants the answer to this question, I think we are in a stage a little bit premature, because we need some time to gain experience. You know, if iPhone and Samsung and Google come out today with 3 phones, you know, and I ask you today which one is better, you answer to me says, let me try and see, and then I can maybe make the judgment. So I think it will take time for physicians all around the world to tackle with this issue, to try to use, if the drug is approved, the 3 drugs in what situation. And because we are a community, as you mentioned this morning, we start to publish in the community, in meeting like that, in scientific meeting. People exchange experiences, and slowly, slowly, you will see that something is coming out and people get better understanding. Guidelines, you mentioned the word guidelines. Again, you can't do the guidelines today when you don't even know what's going to happen. So you need some time, get experience, and then hopefully some guidelines will appear, you know, for this patient I'll use this, for this patient I'll use this, for all the patients I'll use this. I mean, and I think it will take time to figure this out.
And so it's a great point just to add to that as a shameless plug. This is the reason we need everybody on these drugs to stay involved in observational studies, in registries, whether it's with a Conquer study, the TMA registry, because there's a funny phenomenon that happens to patients who are doing well. They stop showing up in research. So if it's been 8 years since your last attack and your vision's perfect and you're walking and your bladder's fine and you have 0 symptoms and your visits with me are social visits, why would you take the time to go online and supply your data? The problem is we don't get a sense of that patient population, so we don't know the true denominator of what's out there. And so I agree completely with the notion of time, but it requires the community to stay engaged when things aren't going so well and when they're going really well. We need to know both ends of the spectrum.
All right, we have about 10 minutes. I was told 4:15 is our hard cutoff. But what questions can our panel answer for you guys?
Yeah, hi. My name's Julia Leffler, and I have MOG AB disease. And I just wanted to ask the panel if any of these drugs are being considered for MOG, or what's the future to add something else to the MOG smorgasbord?
So, if I may, so we enrolled also in our study seronegative patients, and unfortunately, the number that came in were lesser that we would hope for. So we have 17 patients who are seronegative in the study out of 230. Now, we check MOG on this patient, the seronegative, because as you heard earlier, when you have positive, you don't get the other one. So on the negative, we check the MOG. 7 of them were MOG positive out of the 17 were aquaporin-4 negative. So it's a very small number of patients, so we cannot say much about them. It's not enough data. Now, there's a lot, as mentioned earlier, there's a lot of interest now in MOG. I think many companies consider to see if there is justification it is, but is it feasible to do a real prospective study in MOG, and which drug probably may be effective in that. As Ben mentioned, with the satalizumab, the drug from the third company, they show quite less effectiveness on the seronegative patient. We don't know how many of them were MOG or not. So there's a question here if these drugs that are so effective in seropositive in NMO are going to be also effective in MOG or in seronegative patients in general. So I think more studies needs to be done, and I hope that some of those will be done soon to give answer to them.
And if I can, okay, I was just going to have one quick thing on that. There's 2 fascinating aspects of MOG. One is there's some early data to suggest that we may need different approaches for anti-MOG versus aquaporin-4, even though the phenotypes and the symptoms can be very much overlapping. The underlying biology of the immune system may be different in more ways than just the antibody. And secondly, there are groups, and we're one of them, for all of these conditions, aquaporin-4 mediated disease, MOG, and others, working on approaches to treat the condition without immunosuppression. So, because everything we've talked about so far, every drug that we've tried off-label, on-label, about to be on-label, are all immunosuppressants. And we're in the works with one group and have done the mouse studies of, is there a way to get rid of just the confused part of the immune system, leave everything else intact? And so for certain reasons that I won't get into, it's actually easier to do that in MOG than aquaporin-4 mediated disease. And so we're in works with one company to move that into what would be needed for human trials. And MOG is just going to be different because of the amount of time in between attacks is in general so much longer than what we saw in the average aquaporin 4 patient. Just at a population level, it's dramatically different statistically. The trial designs get fascinating in terms of how do we prove what's working and what's not. And so it's going to need the community, it's going to need the TMA, it's going to need everybody involved together to really come together and sort out what a design would look like.
Yeah, and what I was going to say to just kind of tie it all together with eculizumab specifically, or Solaris, in the PREVENT trial is testing solely aquaporin 4 positive patients, so the indication is for adult patients with AQP4. That really comes down to the mechanism of how it works. So eculizumab is a complement inhibitor, and as Dr. Levy had mentioned earlier, the complement system is triggered by the aquaporin 4 antibody, and that's what causes those devastating NMOSD lesions. It recruits a lot of inflammation, also causes direct attack. So because of that, we know how that mechanism works, so we hypothesize that's how eculizumab is working. So we did not test MOG.
And if I can add one more comment, sorry. This is, again, a shameless plug in terms of why we're stronger together. So if we take, we've taken patients in our clinic, and we've published this, of groups who are both diagnosed as neuromyelitis optica spectrum disorder. Some were aquaporin 4 positive, some were MOG positive. They had the exact same rates of optic nerve involvement, and this was specifically in pediatric patients. We found that certain tests of how much damage to their optic nerves looked identical. Their optic nerves looked like they had just been destroyed by the disease, whereas in anti-MOG children, their vision was preserved. Even though the exact same amount of, quote, damage, according to our testing, occurred, they have a different biology, at least on the visual system. And so if we were just doing one condition, we would never be sorting this out. And so when it comes to the clinical trials, both observational and interventional, putting those pieces together makes a huge difference.
I think we have time for one more question.
Hi, I just had a general question circling back to treatment initiation or switching. Maybe this is more specifically for Alexian, since you have the actual approved therapy right now. Are there any beginning or planned like real-world studies looking at treatment initiation, maybe from switching from an off-label therapy to get a better idea on like what that switch looks like?
Sure, yeah, that's a great question. So a little more insight into the PREVENT trial. So when eculizumab was compared against placebo, patients in both groups, eculizumab and placebo, were also on concomitant immunosuppressive therapies. So this could have been things like azathioprine, mycophenolate. There were some exceptions to this for more mechanistic reasons. So for example, something like rituximab was excluded for a certain amount of months. But many of these immunosuppressive treatments were used concomitantly with eculizumab or in the placebo group. As far as how the eculizumab is started and dosed, so it usually has an induction phase. This is done via IV infusions, and it's usually once a week for the first 5 weeks. And then after that, it switches over to every 2-week infusions. And it's a 35-minute infusion. After that, you're monitored for about an hour just to make sure there's no side effects to the medication or allergic reactions. And again, it starts once every week for the first 5 weeks and then switches over to every other week. The dosing for that, you could obviously discuss with your doctor if it does come down to be appropriate for you.
So I'm also diagnosed with anti-MOG, and so for the doctors who clinically are seeing patients realizing there's still a lot more research that needs to be done, what are you prescribing to your patients that do have anti-MOG?
So my first line is steroids to put the inflammation down, and then a very long taper. So during the taper, if you go too fast, it'll trigger a relapse. I think that's a very common experience among my MOG patients. So we go very slow. But then beyond that, if there's a need to continue to suppress the immune system because the MOG antibody is positive, because there are multiple relapses in the history, my first go-to is mycophenolate CellCept. And if that fails, then I switch to IVIG, intravenous immunoglobulin, which at a good dose, it has a very, very low failure rate. But that's a very logistically difficult treatment in the long term because these are multiple infusions per month. They take a long time, they have a lot of side effects, and they're very expensive. So we are working on a clinical trial that would hopefully use the same mechanism as IVIG, but would be a lot easier.
I do what Michael does.
I was gonna say,
Do you think this newer medication would be better because it covers larger amount of the B cells, all the B cells, plasma cells, so it will work better than rituximab, potentially?
So we didn't test, of course, we didn't test it against rituximab. Based on the mechanism and what I described, that they cover a wider range of B cells, there's theoretical possibility that maybe it's going to be different. We have some data in animals that shows that it's more effective in animals compared to rituximab, but we don't have it in humans. So we cannot say that it's more or less effective. What we can say that we tested inebilizumab in a rigorous, the largest animal study ever done, in a placebo design to really check and prove that it's really working. And the results are speaking for themselves. So we know it's working, the inebilizumab. If it's better or not better than rituximab, we don't know.
all right.
So
I'll
we
repeat
did
that.
not include in our study pediatric patient. It was 18 and above. I think you didn't include also
Yep,
pediatric.
same for us, so it was adult patients.
The one of the two other studies with the satralizumab, the Genentech and Sugar ran, include some pediatric patients, but it was a small subgroup of the patient population. I don't want to misspeak about the result there, so I think we need to look at what they're going to publish and talk about. But there were some pediatric patients. I don't know if
So,
Michael, you know? Yeah.
I know Alexion is launching a pediatric extension study in 15 kids to just demonstrate safety. Is
Yes,
inebilizumab going to do that?
Yeah, we actually we're actually planning these days the pediatric again pediatric, but our pediatric probably like yours is going to only look at safety and understanding how the drug is behaving in kids. It's not going to be a large study to show efficacy.
If you've got time for one more. I know a couple of people in the network who've been on rituximab for a very long time that have had ultimately fairly significant damage to their livers that has not been able to be corrected because it's got too far before it's been understood. Now, possibly that's because the monitoring wasn't good enough, but do these other drugs that are being released, do they have a potential to cause that same kind of issue?
You said damage to the liver?
Yeah.
I must tell you that I'm a little bit surprised. Usually this type of drugs, this is biologic, like antibodies, both rituximab and inebilizumab are not usually known to cause damage to the liver. So I will need to check into that. I'm not familiar with that.
There is one. So if the patient had hepatitis, is that the case? Hepatitis B and then got rituximab, then the hepatitis could get worse?
Now, if you talk, so that's a good point. Again, we didn't have it, but if you talk about activation, because you reduce the immune system, any drug that reduces the immune system can lead to activation of certain infections. And some people get their hepatitis B or hepatitis C activated because of the immunosuppression, but it's true in general. It didn't happen in our study because also we took care of it that we don't allow patients with active hepatitis or potential active hepatitis to go in, so we don't know.
Yeah, and I can add to that with eculizumab, again, it's a complement inhibitor, so it specifically targets the complement system, and we don't know that to cause any issues with the liver. So as far as starting the drug, there's no lab monitoring or checking liver function tests or anything like that. It's the main prerequisite is really that meningococcal vaccination that you get 2 weeks prior to starting, but no monitoring.
We didn't hear you the last sentence.
Oh, sorry. One of these patients actually had rheumatoid arthritis quite significantly in the scheme of things while they were on the course of this drug. Sorry.
Arthritis.
Yeah.
Rheumatoid arthritis, yeah.
Rheumatoid arthritis.
So would that alter the likely outcome of what we're talking about here?
It shouldn't.
All right, I'd like to thank our panel for their time, and you guys for your questions.
Thank you, guys.